Right. Hello, everybody that is coming into the meeting. We're going to give this just maybe about 30 seconds here for everybody to actually get into the webinar, because sometimes it takes a few seconds. Looks like we might have everybody. So I'm going to go ahead and get started. Good afternoon and welcome to Whitmix's webinar, Maximizing Your Intraoral Scanner, Understanding the Differences Between Analog and Digital with Dr. John Cranham. Most of you know me already. My name is Bryce Hiller and I'm a digital marketing specialist here at Whitmix, and I'm going to be facilitating today's webinar with Dr. Cranham. I want to begin with just a couple housekeeping items. The first thing is in the upper right-hand corner of your screen, you should see a questions box. Feel free to type any questions that you may have throughout the webinar into that box or into that chat window. And at the end of the webinar, Dr. Cranham will be answering those questions. Next, if you are a CDT, this webinar is approved for 1 hour of CE credit towards your certification. You will receive an email within roughly 1 to 2 days that will tell you how to obtain your credit. And finally, this webinar is being recorded, so we are live on Facebook, we are live on Zoom, and then we are recording on both of those platforms as well. So within about 48 hours, this will be available on our website, on Facebook, and then it will also be available eventually on our YouTube channel as well. So you can check out any of those 3 places if you would like to go back and watch it later, or send a link to somebody else to check it out. So at this point, I would like to introduce our guest for the day. Today we are joined by Dr. John Cranham. Dr. Cranham is a highly respected and renowned dentist in Chesapeake, Virginia. At his state-of-the-art office within a general practice setting, he focuses on cosmetic aesthetic dentistry, implant dentistry, TMJ/facial pain, and solving complex problems with an interdisciplinary focus. He uses his vast experience and knowledge to create healthy, long-lasting, comfortable, and natural-looking smiles. He is an honors graduate and clinical instructor of Virginia Commonwealth University. In 2004, he began lecturing at the Dawson Academy, a world-famous teaching institute based in St. Petersburg, Florida, which led to the merging of Cranham Dental Seminars with the Dawson Academy in 2007. He became a 1/3 partner and its acting clinical director. He held that position until September 2020. To date, Dr. Cranham has presented over 1,500 full days of continuing education all over the world. Today, his focus is on integrating sound occlusal, aesthetic, and sound restorative principles into efficient digital workflows and ultimately coaching doctors on how to integrate them into their practices. He does this under the new umbrella of Cranham Clinical Coaching. With that, Dr. Cranham, as always, it's a pleasure to see you and speak with you today, and I'm going to hand the reins over to you.
Yeah, it's welcome. I appreciate you having me, and for those of you that have worked a long day and kind of tuning in to check this out, I appreciate it. Should also just kind of say that the newest little venture after doing sort of a year under Cranham Clinical Coaching is partnering up with Lee Culp, who again probably has more vast digital knowledge than anybody, and the new umbrella is Cranham Culp Digital Dental, but still providing the same goal of accelerating the global dental community to these digital workflows that I've just been dreaming about now for 15 or 16 years, and now just becoming to full fruition here with what we can do. And I think it's appropriate for us to have a discussion a little bit about scanning, because I do think that's where it all begins. I think most people today have a belief in this technology. A lot of different options out there that can kind of get confusing, but they all work pretty well. And one of the things that I want to just kind of reiterate is, scanning is the place where the data begins. It's where we start getting that mesh of the mouth where we can do so many things with, whether it's planning a case or doing crown and bridge or veneers or partial frameworks or even digital dentures today. So I want to talk about scanning from the standpoint of how you're going to get the most out of this. Talk a little bit about the benefits of digital over analog, and then talk about some of the other things that we can do by adding maybe a piece of hardware, some software, so we can get most out of the data that we obtain from the scans. So the first thing we want to do today is understand the tremendous benefits of intraoral scanning and how to get the most from this amazing technology. And I think that when we buy a scanner, we're kind of shocked at first that maybe the thought is that as soon as you have a scanner, you can start printing models, or you can have a scan and immediately do a wax up or whatever you're thinking with it. And you find out pretty quickly that with most scanners, you're pretty much just gathering the data. Now, there are some out there, like Veripulse has a workflow that where you can send a scan directly to their printer. We'll talk about that a little bit, but by and large, understand that the first step is to obtain accurate and efficient intraoral scans, and then understand the different things that we can do with it as you grow the digital footprint in your practice. I'll talk a little bit about crown and bridge, because that's maybe the most frequent thing we do, and understanding that the soft tissue management needed to take a scan and get a really accurate digital impression. The tissue management is a little different than when we're using a traditional impression material, and I'll explain that. We want to align software with your scanner to maximize the workflows in your practice. So you can kind of talk about some different things, but knowing your own practice and the things that you want to do, the more you can manipulate the data in-house, maybe train your assistants to manipulate the data in-house and do various things with it, you can start creating outputs, whether it's a bite splint or a wax up, or maybe even you're even going to get a mill and start to design and fabricate permanent restorations. And the people that I'm coaching now, I've got all the variety of people using different things. And the last thing is, deciding when you're going to outsource to a laboratory, the best way to do that. And that's the balancing act that I play. Like, what am I going to use a lab for? What am I going to do in-house? And I'll tell you what basically we do. But what I can tell you is that just from the 60 or 70 docs that we're working with now, there is a large variety of people in how they're using these workflows. So let's look at the hardware needed and the ROI on this investment. And again, as you look at an intraoral scanner, what I want you to be thinking about is data collection, right? There's not much in the scanning software that allows you to manipulate the data. And so we want to get a scanner that's going to allow us to efficiently scan, to collect accurate data, and understand that the scan that you're creating is just a very thin 5-micron mesh of whatever it sees. And so whether that's a tooth preparation or it's a ridge between two teeth, all that stuff can be captured really, really nicely. If you still have doubts about whether scanning works, let's just kind of look at a few little barometers out there that was in the literature. I found this one interesting. Looking at Invisalign, the Invisalign production team noted a 4% rejection rate with PVS impressions compared to a 0.4% with intraoral scanning. So that tells you, that's a company that's trying to accept your scans the best they can so that they can make aligners and bill you. So kicking back, 4% is quite a feat. And it also tells you that with just a 0.4% with scanning, that scanning properly is better. This was by a group that I respect that was in Clinical Oral Investigations. Their basically summary of this article back in 2021, just last year, is that intraoral scanning is faster than conventional impressions, independent of the size of the area to be scanned. So you could compare a quadrant to a full arch scan, and it's going to be faster. It definitely improves the overall patient experience. I hear that over and over. people blown away by the scanning and not wanting the mush in their mouth. It is, as part of a digital workflow, is able to provide reliable prosthodontic outcomes. Okay. So one of the things when I'm looking at digital, there has to be benefits to going digital, and it has to be at least as good as what I was doing before. And my experience with scanning is it's certainly as accurate. Johnny Burgess is a friend of mine. I was in some key opinion leader meetings with him over the years. There's a lot of research, a lot of things here, but the bottom line is that the current studies suggest that digital crowns can be more accurate than conventional impressions. Okay, so a lot of good things there, but we're talking about something that can be as good or more accurate than conventional impressions. So if you're wondering about the accuracy, the only thing that I see in the literature that may be not as good as traditional impressions is when you're looking at cross arch implants. So all on 4, all on 5, all on X type case, I still will use impression copings and use a polyether impression for that. And there is some dimensional instability in the whole arch. Now, if it's single teeth in an arch, I've got no trouble with that. But when you're cross arch and it's one bar that has to fit, that is one of the areas that could be problematical. Now, tips for scanning crown and bridge, again, comparing to a traditional impression material. One of the things that was very popular with a traditional impression material was to use a 2-chord technique. And what we would do is put the first one in a small chord, put a bigger one up top, and pull the top one. And the goal with impression material was to get the impression material past the margin so that when the lab poured in stone, that they could see the vertical wall of the root so they could trim it back precisely to the margin. What's important to understand is that in a situation with soft tissue, if the soft tissue collapsed over the margin a little bit, as long as the impression material got around the corner, you'd still have a good impression. But remember, with scanning, it is line of sight. So if you have the 2-chord technique and the tissues go like that and the scanner cannot see the margin, your margin is going to be shy. So because of that, what we do with scanning is we just put in 1 chord. We don't have to push it down as far. And all we really need is to expose just the tip of that margin. And since we're scanning in color, if we can see margin, then chord, and then tissue, it's pretty easy for the lab to see that. Now, what we have to do is just, again, understand the scanner is never going to see the vertical wall of the root, just can't get to that angle. So it's line of sight from the top. So if we look at our example here, this particular molar of this molar looks pretty good. But if you're looking over here on that mesial, you can see where you see the cord, and then the cord disappears and it comes out the other side. So if we scan that, we might in fact miss that mesial. We should put a little bit bigger cord in, and maybe we have to take a little laser electrosurge and just trim that tissue. You look at the other example and you can clearly see the margin all the way around. That one is appropriate. So similarly with this one here, looking down the long axis of the tooth, line of sight, we can look down the long axis with our mirror and see that one is going to be good to go. So my tip for you is you definitely also want to keep the site bone dry. My preference is to scan the area, right? Just get your scan, full arch scan, and then cut your prep out of that. And then you're going to go back in and you can really blow air and dry that. My assistant will get the full scan, cut it out, then I'll come back. I'll hold the scanner. She'll be blowing air on the prep, and then I go in and just scan the tooth that I'm working on, or the multiple teeth that I'm working on. Works really, really well that way. And again, with the air, it's not allowing fluid kind of get on that margin, because again, the scanner can go right through the fluid, but it can create sort of edges that aren't completely clear. Use a single cord large enough to push the tissue away from the margin. Line of sight is key. And again, don't take the cord out, just leave the cord in there. As we look at just getting good scans, One of the things to just remember, if you watch somebody who's good at it, they're going to follow the recommendations depending on the scanner. We've got the Varipulse, we've got an iTero, we've got the Carestream, we've got experience with both E4D as well as the OmniCam from Sirona. So we've been scanning a long time. They both have a little bit of their idiosyncrasies, so you want to follow the recommendation. But notice that with good scanners, they're not looking in the mouth, they're looking at the screen while they're doing it. Another good tip is these Optogates work really good. They're vinyl. They have a smaller inner ring and a larger outer ring. Just kind of holds the lips out of the way. And then once you start scanning, again, keeping your eyes, getting your assistants to keep their eyes on the screen and rolling the way the manufacturer recommends it is good. And then what I would also say is a lot of the companies are pushing for getting the fastest scan they can. Take a little bit more, another 30 seconds, and get all the data. Make sure you get the free gingival margin and you get the palate and you get all the things that you need. Because if you start doing wax ups or doing things to this, you may need that data. It's kind of like, back in dental school, and they were picky about how we got our alginates, that we would get all that data. So that can be done really, really effectively and very, very efficiently. So again, what I want you to think about it is that, scanning by and large is replacing impression material. It's allowing us to get data that we can then send to the lab. And if we send to a lab, understand what the lab has is software to be able to take the scan, the mesh, whatever you want to call it, and then do things to it, whatever we prescribe, whether that's making a crown or a bite splint, or maybe they're going to do a wax up. And what we should be thinking about as practitioners is that the software is still available to us as well. And so for me, working in the analog workflow for so long, where I would take a face bow and I would take a wax bite record and I would be, pouring alginate or polyvinyl impressions and mounting them, the casts on articulators. And that was a long, laborious process in order for me to treatment plan. And I can tell you that now, utilizing software, we don't do that anymore. We're doing that all virtually on digital instrumentation that, quite frankly, saves me hours of time. There was a time that I really thought that doctors had to learn analog before they learn digital. I just don't see that anymore. I don't think that anymore, because I'm seeing too many doctors that are learning about occlusion, but don't necessarily want to do the stone method the way that we did it for so long, because they see how much time this saves and that the increased accuracy, less chance for error. The digital protocols remove a lot of pain points that, quite frankly, took me 2 years to learn in the analog world. So I want to touch on that, on how we can get the most from our intraoral scanner, and think about what can we do with the data that is gathered from a scan. So the first thing I just want to point out is that the software, there's kind of two types of software out there. And so whatever kind of scanner you get, whether it's the Varipulse, the Trios, the iTero, the Carestream, or the Medit, that data or that software that comes with the scanner is pretty much 100% related to gathering the data, and maybe a mechanism or two for you to be able to show things to patients, like the first point of contact or the concept of a health scan where you can compare one to the other. But pretty much that is what that does. It's just about gathering the data. Now, the other type of software that is available to us is lab design software. And what I want you to think about lab design software is software that allows us to manipulate the data. And I think about it as replacing the model trimmer, the articulator, and the waxing instruments. So all the things that we did to our cast to be able to put it in an environment where we could study the jaw movements and start maybe looking at photographs and visualizing where we're going in space. And there's a couple of options out there. Exocad is one. What we're using is the 3-shape premier lab software. And to be clear, this isn't the 3Shape software that comes with the Trios. This is the 3Shape software that the labs would buy. And again, powerful software. You can make crowns, you can make bridges, you can make veneers, partials, dentures, a lot of things with the software. But what I'm going to cover is basically the things we do with it. It allows us to do a quick occlusal analysis on a virtual articulator. It allows us to do two-dimensional cosmetic imaging. I'm going to show you all this in an example in a little bit. It allows us to evaluate the occlusion for potential equilibration. Digital design, sort of diagnostic waxing, whether you do it or you do some of it and get the lab to finish. Prototype provisional type fabrication. And then a big thing in our practice now is we're making the best orthotics of my career with the Splint Studio that's in this software. Let's talk about just occlusal analysis for a second and think about the old way, the traditional way, where we would take a face bow and we would take impressions and we would take a centric bite record. And then we would take those impressions and vacuum mix stone and pour them in, let that set up and base it. And then we would mount the maxillary cast with the Whitmix face bow system. And then we would mount the mandibular cast after attaching the mandibular cast to the maxillary cast with a hot glue gun. And then once that's set up, then we would add more plaster and get it all smooth and polished up and get it presentation ready. Dr. Dawson taught us to take great pride in this. And this is the way I did it for an awful long time. If I'm honest, after learning it, it probably took me about a 2-year period of time before I was really looking at my articulator, looking at my articulated cast with confidence that I was in fact centric relation. So that 2-year period was a little bit dicey. It made me anxious. And I see that with students as well. So we start comparing to what we can do with the virtual articulation software and start looking at the different things that we can do with it. I think you're going to find that it is a lot more efficient. So let's just cover what this 3Shape Premier software does and how we get these scans and bring it in and do something that we would like a trial equilibration or something to visualize for Invisalign or maybe even a wax up. The first challenge is how do we mount the maxillary cast? I'm going to go through that with you. But the one thing that is interesting in the analog world is that the really challenging thing was to mount the mandibular cast. And what I'm going to show you is this is actually the easy thing, because if you use a Lucia jig or if you use a leaf gauge or something to capture centric, when you scan that buccal bite, wherever you scan it, the mandibular cast is always going to come in with the maxillary cast into the software. So we don't need to use wax. We don't need to use any of that stuff. We just need to scan the buccal bite where we want this to be. So I'm going to take you through this. Now, when we bring the maxillary cast in, what you're going to see is in the software, there looks like a little platform with teeth outlines on it. And you're going to see us putting the maxillary cast on that platform. And what that's going to do is it's going to put the maxillary incisal edge 100 millimeters from the condyle. It's going to use something we call Bonwell point, which is that 100 millimeter dimension that has been around in the literature for a long, long time. This study back in 2015 that's up here actually compared this Bonwell point 100 millimeters to ear bows and found that the air between the ear bow and this Bonwell point to be about 10 millimeters. In other words, we forget sometimes that the ear bow is also based on an average, okay? An average distance from the ear canal to where that condyle is. So let's just show you in our practice, when we're going to mount models, we'll obtain scans at the exam and the scans go up into the cloud. And my son works with me in the office and his job is to mount the models and to get the cases ready for me to do a wax up. Because this is lab software, we're going to start with filling out an order form. And then what he's going to do is once he fills out the little order form, just takes a minute, he's going to grab the scans from the cloud and he's going to bring them in. And once he clicks on them and opens up the software, and see them coming in right now, you're going to see the maxillary arch and you're going to see this platform. He's going to hit the auto button. The platform is going to attach directly to this platform, the maxillary arch is, and then all he has to do is go ahead and align the maxillary incisal edges to this platform. Now we get to this point, he can go ahead and tip this around. He'll go up to the top right and slide in where the mandibular cast is. That now is brought in centric relation. And if he clicks on the articulator, this case is mounted, right? And that fast. So again, the pain points that were involved in mounting casts, the days of learning that I went through and practicing are pretty much gone with this software. It's pretty incredible. And there isn't anything that I can't do to those casts, I'll demonstrate in a second, that in a digital world that I can't do in an analog world. So is this Bonwell point good enough? That's the big question. Again, this is the study from 2015. Basically said the occlusal plane angles are all similar, comparing ear bows to the Coyce face bow. Coyce face bow is based on this Bonwell point. Size ledge position of the face bows were similar, but varied from the skulls from 9 to 10.3 millimeters. So I have just found that there is really no difference. This 100 millimeters has worked spectacularly well for me. And so key point, I've seen zero difference in the accuracy when mounting using the 100 millimeter Bonwell point average than using an ear bow. You want to know where this Bonwell point came from? It goes all the way back to 1864 when Dr. William Bonwell described the Bonwell triangle, and these measurements were discovered. So to be clear, basically the maxillary cast is mounted in the 3Shape Lab Premier software using this 100 millimeter Bonwell point average. The mandibular cast will appear in whatever position you scan the buccal bite. Your cast will be mounted accurately in minutes, and there's no wax. And so again, you think about the analog way, the expansion and contraction of stone, the expansion and contraction of mounting stone, wax distorting, bubbles on your cast where the wax won't go in. There's so many ways it can get off. I've just found this to work extremely well. Now, the last thing that a face bow does is it captures the plane. So if you have a cant to the maxillary plane, when the ear bows in the patient's ears, we'll look at the eyes and we sort of level it. And so we have to have some way to account for that. And there's a couple ways that we can do it. And the simplest way we can do it is we can actually, really cool, we can get the maxillary cast aligned, and then, how it's just going to be attached to the platform. And then the second thing, two ways we can do it, but the easiest way is to just use this full face retracted photo. And essentially what we do is when we go ahead and get this thing rolling, we use the patient's photograph, and in the software, we can put a dot on the two pupils and get it nice and level. We can take 4 points on the cast or on the photo and put 4 points on the cast on the articulator. And once we've aligned those casts, the models and the photos will be completely aligned. And what's cool about that is we can now basically put our articulator right over the patient's face. And so do that one more time. Once we are there, then we can basically just take that articulator and we can move the articulator. The cast won't move, but we can move the articulator so the articulator is in line with that interpupillary line. So this is a really cool way. So we're within the 100 millimeters on the arc of closure. We take care of the cant using the patient's photo. If we really want to be accurate and we want to be on the actual arc, one of the easiest things we can do, if we're taking a CT scan for something else, we can go ahead and bring that in and overlay the CT right on the articulator. And so we can then put the casts on there, aligned with the teeth, and then move the articulator so that the condylar axis is right over the condyles. You also saw we can bring face scans if we want. That's kind of another level. So you can imagine pretty impressive for a patient to see their face, to see the bones, to see their casts and all that on an articulator that can also then have the same degree of adjustability in the condylar axis, the Bennett, all that can be adjusted just like you would on an analog instrument. Now, a couple ways to do your scan, and I'm not going to go through all of them in this webinar, but a very simple way, classic way, is to use a Lucia jig, a leaf gauge. And with a leaf gauge, we can just kind of slide forward, back, and squeeze. Squeezing is a good way to load test. And once we really are sure that that does a pretty good job of just holding them where they are, then we can just scan the space between the teeth on either side. And that captures very, very rapidly the position of the mandible against the maxilla in CR. And so very, very rapid, right? We're not heating wax, not doing any of this, and we can go ahead and have the data. Now let's talk about things we used to do with our casts. And, one of the things was trial equilibration. In order to determine whether you could equilibrate a patient or not, classically, we would mount the cast and we would adjust those models until the front teeth touch. So you're adjusting the back teeth until the front teeth touched to see if, in fact, you could equilibrate without destroying the back teeth. And so this is how we did it for a very, very long time. And in order to get to this point, again, had to mount the models, go through all of that. And I can't tell you how many 6 a.m.s I was doing this trial equilibration, because that's when I would do my workup. But it's a time-consuming process to do this. Let's look in the digital world, and I'm going to call this the 2-minute trial equilibration. Because you're dealing with a mesh, once it's mounted on a virtual instrument, when you close the articulator, if back teeth bump, they will actually pass through one another. And we'll use a ghost scan, which is a different color, so we have some contrast. But if I wanted to see how much we would have to equilibrate in this example, what I could do is go ahead and start closing down the cast. And up here, you're going to see me move this over and start closing the articulator down. You can see it start closing on the arc. The back teeth will start going through. You'll see the gray start coming through, and we're going to keep closing this down until we start to just see the front teeth touch. And remember, these meshes are just microns thick. So now that the front teeth are touching right here in the front, just a little tiny bit, I can go ahead and just get it right here. And then I'm going to lock that vertical down, and I can look through my mesh and see how much tooth structure is penetrating through. That's a lot. Do I think I can equilibrate that, or do you think I need to do ortho? I didn't have to spend 45 minutes equilibrating something to know that. Now, another thing that I can use is the slice tool, where I can slice right through that cusp. I can get a little 2D diagram of it. And if I zoom in real closely, I can see where the cusps are penetrating through, and I can measure that. And so if I measure the distance between the blue and that kind of greenish gray, then I know that's going to be how much I'm going to have to cut away. So let's put a dot there. Let's put a dot there, and I can see that that's just about 0.4 millimeters. So I can do this in multiple areas very, very quickly. Now, if you're learning to equilibrate, I don't think this is enough. And what we would do with, like, my daughter, when she's at that point, what we'll do is mount these models. We'll print these models with little mounting jigs or little mounting points, which is easy to do through Model Builder. And then she can do her trial equilibration to gain the skills of learning how to equilibrate. Because equilibrating this, while we can do it, it's just not the same tactile. So I think there's ways around it. Look at that. That's 0.8 millimeters. That's too much. And this is a case that we went ahead and did some ortho on first. Looking at this one, this is one that we're doing a digital design up front. We've also equilibrated the back already. I did the trowel equilibration, and notice how we can bring in the blue model, and this is showing us the areas that we have equilibrated. Just like before, if we want to see how much we've actually equilibrated, we can use our slice tool. We can go right through the blue and the green and get close on it and start to see that the difference between the two in this case isn't very much. Even though it looks like a good bit of the cusp is gone, when we go from one to the other, it's just basically 0.2 millimeters. I'm comfortable equilibrating that. So that's the thing, that's how I did it. I'm doing it now. Now, if it comes time to waxing, like equilibrating and waxing, again, this is how I did it for 30 years. I had my models, I had my little waxing instrument, and we would do all of this. This additive work where we would get to the point where we would see lines in the front, dots in the back, and prove to myself that we could design what I was hoping for. Now, instead of sitting there with my articulator and maybe the computer for my x-rays and photos, that top screen basically replaces the articulator. Still have my bottom screen, I still have my photos, I can look at raw scans, I can look at x-rays, I can look at CBCT images if that's part of it. But when it comes time to actually looking at the occlusion and designing the occlusion, that top screen, which is attached to my laptop with the 3Shapes Premiere software on it, is what we're doing. And again, I was talking to a doc last night who's joining us, and I mean, there's an investment to this technology, but you'd have to pay me a lot of money to take it away because of how accurate it is and how much time I save. So the question is, if the better looking option can be created in way less time with increased accuracy, is there really a choice? And I'm going to show you a more advanced example of that here in a second. Looking at the TMJ Facial Pain workflow, this is again an example of what we do with data. I mean, we start with a cone beam. We're going to get that read by a maxillofacial radiologist. If we're going to go ahead and treatment plan something that is an orthotic, then we're going to scan, but instead of mounting models and all that stuff, we'll send the scanner to a part of the software where I can design and then ultimately print my own orthotic. We can still use PT referrals. Sometimes we have joint surgery, but again, using this digital data first to make a diagnosis at the joint level, having some of the different diagnoses that is available to us from that technology, and then having the capacity to design one of these 4 type of appliances, whether it's the dual arch deprogrammer, the little deprogrammer that I do for short term on clenchers, a full arch Tanner, lower Tanner orthotic on TMJ patients, or maybe even an upper full arch Michigan type splint. The bottom line is all these can be fabricated very, very easily inside the splint studio. And rather than waiting weeks for an appliance, we can design the thing in about 20 to 25 minutes, print it in about 40 minutes. And we're using the Keystone Soft material, which is just fabulous, just a fabulous material. So that's a workflow that when the docs start working with Lee and I, that I really recommend they start working towards. Even if they're not printing themselves, they can design it, send the orthotic off, get it printed, sent back to them, and they can be in business very, very rapidly. It's easy software to learn. So just from a workflow standpoint, again, it is going to begin with a scan. We're going to go ahead and mount the scans inside the Premiere software. We can then design that orthotic very, very rapidly by marking the outlines, and getting the orthotic in place and sort of shaping it, although the AI in this is pretty strong. And then basically being able to work through all of the different jaw movements in the software is really amazing for us to be able to get the occlusion exactly the way we would want it. Okay, that's a good example of the Tanner type software. And then ultimately printing it, getting an STL that we can go ahead and just print. Now, one of the pieces of hardware that you might want to consider after you get pretty good at this is to get a printer. I've got two of the Whitmix ones. I've got that little Vera Build and I've got the Vera Echo, which are excellent. That one on the left is a simpler printer that does the model works and will do some provisional material. The Vera Echo will also do the orthotic, the Keystone Soft, which was very, very important to me. The Sigas, which were also available, are faster. They're a little larger. A lot of the laboratories are using that. I found that the Vera Echo today would be the one that I would absolutely recommend. So just looking at these things and how they snap in place, what used to be a good 45-minute appointment of relining and all that, these things just fit, so most of the time it's a 15 to 20-minute procedure to get them in, and I can get my assistants to dial those in pretty rapidly. Let's look at just a sample restorative workflow and talk about the different ways that we can use this software, that whether we're going to work on it ourselves or we're going to work with a lab. I have doctors working one of three ways with the 3Shape software, where they may obtain the scans and they may fill out the forms that we recommend to communicate to the lab. So in this case, the lab would not, or the dentist wouldn't own the software, but they would refer out and direct the wax ups to be done. And so in type 1, the lab does all the design. The second possibility is the dentist owns the software, starts the design, and then sends it to a lab, sends the file to a lab for them to finish it. A lot of our docs do that. I think one of the best ones is that the dentist starts the design, does the key points to maybe figure out where the central incisal edges go, and then gets that off to somebody in the office, an assistant that's been trained to finish it. That way the dentist can kind of be over the shoulder and directing it. And the last possibility, the way I work with it, is the dentist does all the design. And I have the time, so I enjoy doing it. I feel like I've done the case, but again, in the analog world, I did that too. And so I get that not everybody wants to do that. The benefit is you've got some choices here. And if you decide to get some training from us, we'll kind of take you through a process to figure out which is the best fit for you. Regardless of which path you use, we do use this Facead worksheet that helps doctors figure out where teeth go in space for aesthetic and functional purposes. We're going to run through a sample case here quickly, but I get asked all the time when you're looking at these different ways to do it, whether you're going to be the observer director, the communicator, or the designer, there is definitely advantages and disadvantages to all of them. And that's why it goes a little bit beyond what this webinar is, but there is some, I think, real science behind how you should be doing this, what's going to be best fitting for you. Again, the important thing is if you're going to send a partial design for a lab to finish it, where you're maybe going to go ahead and set just 2 central incisors, that's a pretty good way to do it, because you're just setting up 2 teeth. If the lab can see where the 2 centrals are, they can often finish it and make the details, they get all those little fine details. So sometimes that's what we've got docs doing, is just setting up 2 centrals. In terms of the designer, you're going to have more upfront costs. There's definitely increased doctor time. There's maybe other productive things that you could be doing. But one of the things about being the designer is that I feel like I have complete control of the case when I'm doing it because I've already done it. There's also zero lab costs. It's just my time. I get asked, which one of these do I use? I use all these paths depending on what I'm doing. I do a lot of my own wax ups, but I communicate a lot with Lee, like if I'm doing dentures, and if I'm doing a implant case, he's doing almost all of it. I'm just telling him where the teeth will go. So for me, I do a lot of my wax ups. I do my own orthotics. I do some full mouth wax ups where I'll do start it and then send it off to Lee. Simple implant cases. I'll talk about the lifeboat and maybe another day, but all on 4 workflows, full mouth extraction, immediate load cases. That's where I'm letting Lee handle it, and I'm going to kind of direct it. All right, so let's look at a sample case and then we can wrap up. Eric, 54 years old, mild gingivitis. He's got good stable joints, got no pain. He's got a history of clenching and grinding, moderate wear, deep bite, no mobility, would like to improve his smile. So you just look at him, he's kind of beat up. He's got some diastemas. You look at the tip down smile, his edges are back away from his lip. He's showing nothing at rest, although E is fairly okay. But this is the biggest thing that's getting him. 100% overbite just about, and teeth are splaying. Thankfully, really good healthy perio. Lower incisal plane is worn concave. And he just really would like a nice smile. He wasn't really that aware of some of the worn stuff that was going on, either on his lower incisal edges or his uppers. So we're going to go ahead and take you through this Facead method, which Facead, the first thing it stands for is FAB, which is face, airway, bite. And we want to make sure his profile is okay, that he's breathing okay, that his bite is reasonable. And the first thing you'll notice is if we look at Arnett's true vertical line, his lips are back and you do see a little bit of wear and tear. We went ahead and did his stop bang analysis to screen him for airway issues, and he scored a 4. And with that, we recommended that he goes ahead and get a sleep study. Sleep study actually came back positive, mild sleep apnea, got hooked in with that doc and started on a CPAP. So, I would just say, I don't really want to be the sleep guy in our community, but I think it's really important when you see wear and tear and maybe a facial profile that's a little deficient to kind of help this guy. And then there may be some things we can do dentally to help get his teeth in a better, more stable relationship. His width, his arch form, McNamara study shows us that we should have a minimum of 36 to 39 for right at the groove on the lingual of the maxillary molars, and his is 40. So we have no treatment with regards to orthodontic expansion. We look at the edges of his teeth. We're trying to find a good edge. I kind of like the length of tooth number 9. And when we look at his lower incisal plane, it's definitely concave. Canines might be a little tall. These are short. So we're going to find a line there that we can communicate with the lab. Looking at centric stops, we want all the teeth to contact when he closes in centric relation. It's a little bit heavy posteriorly in CR, but not much of a slide. And if we take a look at them on a virtual articulator and close them down, we see that we probably could do a little bit of reshaping there. Now, the biggest thing that I think we can help this guy, though, is decrease his overbite his overbite through some minor orthodontic intrusion. Right now, he's kind of like this. He doesn't have great stops. It's by the tissue. If we unscramble him and intrude things a little bit, that will give us some room to be able to restore his top teeth without having to cut as much tooth structure away. So maybe a little intrusion, a little minor equilibration, restorative to get good stops. Similarly with anterior guidance and disclusion, we're also looking at some ortho and some equilibration and restoration. So because of that, we're not going to really do a wax up just yet. We're going to make a treatment plan where we've got a little caries or a little actually erosion to watch on 19. We're going to start with Invisalign, then do phase 2 records, do a little equilibration, and we're going to do some long-term resin veneers on long-term kind of provisionals, 21 through 28. And then we'll do some veneers on the premolars and crown 6 through 11. That's kind of what the plan is. Why long-term resin veneers or long-term provisionals? He's just trying to spread the cost out. Kids in college and whatnot. So start with some Invisalign, a little equilibration, do some resin veneers, get the uppers permanently done, and do some nice resin veneers from on the bottom that he can swap out to porcelain when he's ready. And then I'm going to finish him with a guard, and we'll also do a lower retainer, and then of course keep him on a CPAP. So we're going to go ahead and make sure that we got really good guidance in this. You know, we got to have a steep enough guidance to exclude the back teeth. Still have to be within harmony of the envelope of function. Right now, there's some worry that his envelope of function is restricted. Now, again, if we look at his situation where his bite is deep, what I'd like to do is decrease the overbite and increase the overjet. And we can do that by intruding his teeth a little bit and then changing the interincisal angle. And so this is going to be primarily my goal. I don't want to just push his tooth out. This is correct. This is incorrect. The other way to decrease his overbite would be just open the vertical. But if you open the vertical, you got to do at least a whole arch, which he does not need. So we're going to be looking at this as doing a little ortho. So we take him through the Invisalign. There's pre-op, his pre-op Invisalign or pre-op picture. There he is. Actually, there's pre-op, there's post-Invisalign. There you go, pre-op, post-Invisalign. You can see how you're seeing a little bit more of the bottom teeth. Things are a little bit straighter, but I'm going to be restoring these edges, don't forget. But this is the biggest thing. There's the overbite here. This is the pre-op, and we did it by a little bit of extrusion in the back as well as intrusion in the front. All right, now we can start our design work, and this is when we're going to scan again. We've got the teeth marked that we're going to restore. If we go through our fab, the face airway bite and the archworms are good at this point. And now what I'm going to be doing is making some notations of what I'm going to do the edges, the lower incisors and the upper incisors, how I'm going to dial in my stops, how I'm going to get my anterior guidance, and some notes on posterior disclusion. And this is where, if you filled out this form, you could just send the scans to the lab and let them do it. Or you can do it yourself. And this is, for me, what's so much fun, is to be able to take these scans, close it down, get my trial equilibration dialed in. I can go ahead and look at my facial profile to see if there's any changes. That looks good. Arch forms look good. You can really see the wear in these scans, why we're restoring them. Same thing on the bottom here. And now what really gets fun inside of 3 Shapes is starting to design your restorations. So I've got the tips of my canines a little bit strange because I'm trying to pick up the mesial of the upper. He's a little bit class 3. So I can kind of look at my lower incisal plane. The blue shows me where his teeth were. The white is where we're going. I can do some imaging to be able to see where I would like the edges to be. And we can even make this porcelain if you'd like to kind of see how this looks. And then we can take that same software now and bring in restorations to plan precisely where I want my edges. Now, what's great about the software is you're not waxing, you're actually bringing in teeth, actual teeth that may have been created by Lee Culp or Matt Roberts. We have all these molds that we can choose from, and we'll get the edges exactly where we want it. Then we can start creating our stops. Again, if we have some equilibration in the back, we can figure that out, figure out where we need to adjust and dial that in. And then it's getting the stops on the front teeth and the cingulum. You can see where I've got my lower canines just catching the mesial of the upper canine, visualizing that. And then it's just a matter of making sure we've got disclusion. So letting the articulator go and then being able to see our design is providing that guidance. No ability to rub on the back teeth. So once we're here, this is where printers start to come in, because we can take those designs and we can send it off to our printer, which then needs to be washed in the wash station. Then it needs to be cured in the curing unit. But what we end up with is beautiful wax ups, far better than anything that I could have done myself. So great embrasure form, size of ledges are where we want, gingival contours are good. And we'll take a silicone matrix of that and then transfer it to the mouth. And once it's in the mouth, just like in the analog world, we'll start studying it. Again, this patient's been equilibrated now. I've done bonding on the lower edges. We've got a provisional one up top. And we can sort of start to see the transformation from pre-op to post-ortho to now provisional restorations. And that's starting to really take shape. This shows you what we did at the lower incisal plane with our bonding. So those will kind of be long-term temps. They're not splinted. Those are individual bonded restorations. Again, provisionals up top. And once we're comfortable with where all this is and we like the occlusion and we like, he's giving me the thumbs up on the aesthetics, what do we do is we scan the temps. We've already got a scan of the preps and the lab is just going to marry those two. And they can really put the provisionals right over the scan of our preparations and they can copy these edge and incisal edges. They can copy the lingual contours and they can see the exact disclusion patterns that exist in the provisionals that we like. And so we'll copy those accordingly. Final restorations are in now. These are translucent zirconia restorations done by Barb Warner at Knight Dental. Did a really nice job for me. But again, the design work really came from the work we did figuring out where the teeth go in a digital world. And cool to do a case like this and have it never even, touch stone once. Here's a step down smile. Notice how we're following that intervermilion border, which is exactly what we want. Incisal edge is right on that intervermilion border. That's the principle we're shooting for. Notice how pre-op, how this was back because of the wear. We're building it back out. There's a nice smile. And again, keying off of that one central incisor, that tooth number 9, which I keyed on. And then just some soft tissue ones up close. So as we finish, look at it before this, the ortho, Invisalign, and we're looking at the temp and then the post-op. That's our four things here. So we get asked all the time, where is the ROI using scanners and digital workflows? It comes from seeing your preps, your margins, and impressions better, creating better fitting restorations and decreasing remakes. So there's any question, just the data from the scanner is going to make you better, just being able to see things better. It comes from mounting models in minutes rather than days. This has saved me thousands of dollars a year, just in the time it took me or my team members to do some of those things. It comes from rapidly creating far better outcomes with your digital designs or wax ups. It comes from being able to design the best orthotics of your life in 15 minutes and printing them in 30. It comes from implementing other workflows to create surgical guides, ortho aligners, night guards, kind of goes on and on and on with regards to that. It comes from getting a reputation to being on the cutting edge. I think that's important if you're trying to be kind of that go-to dentist in your community, and it comes from saving time and increasing predictability. What I would say moving forward is I do think step one, if you're into scanning and new to it and or been at it for a little while, is focusing on obtaining accurate, efficient scans. Take some of the recommendations I gave you earlier, but you want to capture all the pertinent data. Just don't focus on speed. Get great at scanning, get your teams great at scanning, and you'll have a lot of fun with it. Step two is consider adding additional hardware like printers and software that allow you to manipulate the data from the scans and create in-house patient solutions, like being able to do your own wax up / designs, orthotics, patient aligners, dentures, final restorations. There's so many things you can do that. And I'll say the Vera One is a great solution. Their idea behind the Vera One is for a doctor to be able to get a package that has a lot of these bells and whistles that's kind of customized to you, but it's possible to get a scanner, a printer, the 3Shape software, and even some training from us to be able to help you really get rolling. And then step three is get training to smooth out the transition. Whitmix provides great support and great training. And it's been really a pleasure. They've supported what Lee and I are doing at Random Culp Digital Dental. They're the support group behind our training. But if you are wanting to do this at a really high level, then I think that getting some training, a coach like what we can offer, may be in order. If you have interest in that, that's our website, and we would be happy to talk to you anytime. So with that, Bryce, I am done. I don't know if we've had any questions pop in or if they've got any questions, but I think that takes us a little bit. I ended about an hour, and
yeah, we have a few questions that I'm going to throw your way here. The first one is, how do you scan the bite if the patient is edentulous in the upper and a couple of remaining teeth in the lower arch?
It's a great question. So is that if it's edentulous? Is that right?
Edentulous upper and then a few remaining teeth.
So like anything, if you don't have anything in the mouth to occlude against, you're going to have to get something in the mouth. So that might be that you have to do a scan or a traditional impression and get a record base. What I find is that most patients that are edentulous have a denture. It's very rare for me to see somebody that's been walking around without teeth to have something. And so what we do, I did one today, completely edentulous patient, unhappy, hadn't been wearing anything through COVID. And so when she came in for the consult, I said, do you have anything? Do you have any old denture? So I have a denture, I just haven't put it in a while. And I said, well, bring it in. And so when she brought it in, it didn't fit very well. So what we did is the first thing we did was a soft line. We roughed it up, put the adhesive in it. We use a soft line, just called soft line from Kerr, and put it in, border mold it, get a good impression, did the same thing to the bottom, and then adjusted it so that in centric, it was hitting pretty even. And then what the team does is they take the denture out of the mouth, and in their hand, this is what's important, in their hand, they scan both sides of the denture, intaglio and all the teeth, do the same thing with the other one, then put it back in their mouth and scan the bite. And when they do that, now the lab can take that data and take it into the denture workflow, which is inside of 3Shape, and start from there. So there are some other ways to kind of get around it, but like I said, I haven't really run into anybody yet that doesn't have a denture. Now, the easiest ones to do are actually the immediates. When they've got a few teeth, as long as the teeth occlude at some vertical, you can scan the whole arch, upper and lower, and have them bite and scan that. And the labs can extract teeth and do a setup, get some photographs in there. And then the first thing you're printing is a prototype. You don't have like a wax try, and there's no wax brim or any of that stuff. It's just something that we put in and then take photos of and work from there. But I've had a ball with digital dentures the last 6 months. We've really implemented the workflows.
Awesome. Awesome. Another question that we have is, what is your scanning path for a fully edentulous arch?
That's kind of what I just said. So I don't feel comfortable. I don't think you can scan very well a fully edentulous arch. You might be able to do it on the upper, but even back by the tuberosities, it can be difficult. And on the lower, it's really difficult in the retromylohyoid areas and everything. So I think the way you either have to do it is you could, if you're going to take an impression, you could take a traditional impression and scan the impression and start there. Or like I say, if they have a denture, and they usually do, then I'll do a bunch of messing with the denture. I might take some compound and extend it and then do my soft line, and then I'm scanning that denture, and it works really, really well.
Cool. And then we have one more, if you still have a minute for us here.
Sure. Yeah.
Do you find crossing platforms, say from like Serena Prime Scan over to 3Shape lab software, has more room for error in that orthotics don't fit perfectly? And this is coming from a technician. We can't seem to dial in a seamless fit from scan to print in the context of.
Yeah, I don't see an issue. One thing that I would just say is if you're finding like one particular scanner, it's my experience with working with all these docs, and I've got some Prime scans, I've got some Vera ones, I've got some Medits, I've got iTero, I've got some of the Trios. I mean, they all seem to get good data. Now, what I found to be the absolute best for an orthotic is that we will use a leaf gauge, and we will put enough leaves in there between the teeth and kind of get them back into centric, but set the vertical with the leaves. So I kind of look back in there, and I like to have the teeth apart at the vertical that I want the splint to just fill in the space. And so the other thing that I will tell you is with the Keystone Soft material, I tend to wrap, like if your splints are loose, I'll see that sometimes. If the splints are loose, sorry about that, I will maybe go up the facial contour of the teeth just a little bit more, so that when the Keystone Soft goes in, it's engaging both the lingual and a little bit of the buccal undercuts. And since I'm doing that, they really snap in there. And again, don't let the soft and Keystone Soft bother you. It's not rubbery, right? This is still a hard material. It just flexes a little bit. And so I really liked it for that. So the message I would say is see if you can just bring it up a little bit more if they're loose, and then take your bites, take your scans at the vertical you want to make it, because then it removes any of the need to open or close the vertical dimension on the articulator. And what the splint software does very well is the vertical that you're at, it will just fill that space in. Like it's just going to fill the space in and make both arches. And since we've been doing that, we've just had unbelievably good fitting orthotics that don't really require much adjustment. But I will say it did take us a little fiddling to figure out exactly where to put the line. And that's something we certainly can share.
Okay. Great. We do have one more that came in. Best retraction materials for scanning crown preps.
Yeah, so I'm sort of a little bit old school, but I really like that Ultra Pack. UltraDent has that braided cord. And now the tip is, though, I don't know if I mentioned it, but I tend to use, one cord but bigger. So, we used to put the 00 cord and then the 0 on top. It's not uncommon for me to put 1 0 or maybe even a 1, because what I'm trying to do is get the tissue away from the margins, so there's nothing hanging over. And then I also have a laser. So if I feel like something's not in the way, I'll just trim that little tissue there where the cord is. I've tried to use the laser all by itself, but I feel like the cord does do a nice job kind of keeping the crevicular fluids dry, so you can get a really clean, dry scan of the margin, which I think is critical.
Awesome. Thank you, Dr. Cranham.
Sure.
That looks to be all of the questions. So with that, a couple little points that I want to close with. Again, just to reiterate, keep an eye out in your email for the CE credit instructions. First of all. Second of all, you're going to see a little poll pop up on your screen here that's going to ask you if you would like to be contacted by a Whitmix representative. If you have any product questions or you want more information about some of this technology, you can choose yes, and one of our representatives will be reaching out to you. The last thing, just to reiterate again, is that this was being recorded. So if you want to go back and watch this, you can do so at any time. It will be on our Facebook page, on our website, and on our YouTube channel. And with that, I want to give a huge thank you to you, Dr. Cranham. It's always awesome, hearing from you and getting your expertise. So super grateful that you were able to join us today, and hopefully we can have another conversation soon.
And I'll see you Monday.
Absolutely. Looking forward to it.
All right. Thanks, Bryce. I appreciate it. Thanks, everybody. Take care.
Bye.